Okay. These are my disclosures. The 5 mistakes I will talk about: screening asymptomatic population, using ineffective diagnostics, adopting a wrong treatment strategy, failure to check eradication, and treating children as adults. Yani, there will be some few slides for each one. So, screening asymptomatic population, according to the American College of Gastroenterology guidelines, there is insufficient evidence to support routine testing for and treatment of H. pylori in asymptomatic individuals, even those who have positive family history of gastric cancer, or those who have lymphocytic gastritis or hyperplastic gastric polyps, etc., and hyperemesis gravidae. So no recommendations can be given at this patients category, but there are a lot of other indications to test patients for and treat for Helicobacter. For example, patients who have peptic ulcer disease, patients who have multiple lymphoma, who have gastric mucosal lesions that have been resected and show advanced dysplasia, patients who have dyspepsia or who have long-term use of non-steroidal anti-inflammatory drugs or anticoagulants. Those category of patients, they should be screened and treated for H. pylori if if the result is positive. And also patients who have iron deficiency anemia, unexplained iron deficiency anemia, or B12 deficiency or ITP. The second mistake is using ineffective diagnostics. As all of us know, we have all these armamentarium of diagnostics. You can use histopathology, you can use rapid urease test, urea breath test, etc. But the most accurate one to use from the non-invasive tests that is currently present in Egypt is the urea breath test, either carbon 13 or carbon 14, because the other tests, the rapid tests are not accurate. The stool antigens, even the monoclonal ones, has to be validated against histology to be used in the community. So, according to the Maastricht guidelines, the statement 12, if serological methods is used for Helicobacter pylori detection, further test whether using urea breath test or stool antigen to confirm the diagnosis of Helicobacter pylori. So, serology is not enough anymore. Adopting a wrong treatment strategy, you have to have a strategy for treating patients with Helicobacter pylori. Most of us see patients who have many courses of treatment, who come from different physicians with like 7 or 8 prescriptions. We have to ask them about the antibiotics they have received before, because we should not repeat the antibiotics. So before treating Helicobacter pylori patients, you have to confirm the diagnosis. Please make sure that the patient is diagnosed by a very sensitive and specific test. Number 2, ask about any previous treatment attempts, and please don't repeat treatment. Don't extend treatment more than 2 weeks. It is not beneficial. Use a proper regimen to treat your patient. If the patient is allergic to penicillin, use a non-penicillin regimen. If the patient has failed treatment before with levofloxacin, don't give him levofloxacin again, because this will only increase the resistance. Explain treatment to the patient and explore if the patient is having some barriers to the treatment. If the patient is having some barrier to be compliant to, for example, large number of pills, don't give him large number of pills. If he is not compliant to many times of antibiotics, like 4 times a day, don't give him 4 times a day. Give him twice a day, for example, the high-dose dual therapy. So you have to customize the treatment to your patient and to ask him if there is any barrier to take his treatment. These are the regimens that we have been using since 2018 or 19, since publication of this Egyptian recommendations for Helicobacter management. This will be updated this year, and we will have demic control. A lot of salvage therapies. We have like 7 salvage therapies nowadays. This is the first one. Still, the first line therapy is a standard triple therapy, because we can extend or boost the effect of standard triple therapy by using vonoprazan or using combination with bismuth. But we will have many salvage therapies. The first is the concomitant bismuth quadruple. The second is the concomitant non-bismuth quadruple. Third is levofloxacin. Fourth is load therapy. Fifth is co-formulated capsule, which is the Bilera. Second, sixth, or sorry, 1, 2, 3, 4, 5, 6, and the 7th is the rifabutine. So we have around 7 salvage therapies that we can use nowadays in 2024. The next mistake is the failure to check eradication. Every patient treated for Helicobacter should be checked for eradication. And this is present in the guideline also. The American College of Gastroenterology recommends that each patient who received treatment for Helicobacter should be tested at least 4 weeks after eradication of treatment, and he should be off PPIs for 1 to 2 weeks and off antibiotics for 4 weeks at least. Treating children as adults. Children are not like adults. They have separate guidelines, different from ours. So we have to ask your colleague, the pediatric gastroenterologist, if he would like to treat this patient or no. Please don't treat pediatrics because we are adult gastroenterologists and they have different guidelines. For example, the European Society of Pediatric Gastroenterology and Nutrition, they recommend against test and treat strategy that we usually use. We usually use test and treat strategy for every patient who have gastric pain or dyspepsia, and we treat them straight away. They don't use it. They recommend against it. Number 2, they recommend against diagnostic testing of Helicobacter pylori as a part of the initial investigation for children with iron deficiency anemia. In adults, if we have a patient who have unexplained iron deficiency anemia, we screen them for Helicobacter. In pediatrics, they don't do that. They diagnose Helicobacter pylori either by histopathology. This means that the child has to have endoscopy and biopsy, or even with positive culture, if this is applicable or this is feasible. So they are very strict in diagnosing Helicobacter as a cause of epigastric pain in children. They have to do endoscopy, they have to take biopsy, and it is preferred also to do culture to give them specific antibiotics according to the culture and sensitivity to avoid exposing the children to too much antibiotics in the early life. These are the doses usually used for children. We classify the child either is having a body weight of 15 to up to 25 or 25 to 35 and then more than 35. Simply, if the child is between 15 and 25, he will take half the dose of the adult. If between 25 and 35, 3/4 of the dose of the adult. If they more than 35 kilogram, he can take the same dose of the adult, and they use bismuth also for the children who have more than 10 years or less than 10 years with these doses. So my take-home message is these are the mistakes. Don't screen asymptomatic population unless they have an indication for screening. Use ineffective diagnostics. Please do use the most effective diagnostic that you have in Egypt. Nowadays, I know that the rapid diagnostics for the stool antigen are not sensitive or specific at all. Nobody in the laboratory is using the monoclonal ELISA-based stool antigen. Nobody is doing this. So please use either histology or rapid urease test or the urea breath test. Adopting the wrong treatment strategy, please adopt the ARATS treatment strategy. Ask the patient about the previous attempts for eradication. Don't give him a drug that he may be allergic to. Could discuss with him about compliance, the importance of compliance to completing the course. Check the patients after eradication, at least 4 weeks after eradication, and don't treat children as adults. Thank you very much.